Mike Gibson, Navin Kapur, coming to you live from ACC 2026. And Navin, I've been waiting on this trial for a long time. As I just said to you in the pre-interview, nothing that's easy is worth doing, but nothing that's worth doing is easy. I know this was a tough one. Congratulations on getting it done. This is a trial of ventricular unloading in the setting of MI and shock. Talk to us a little bit about what you did and what you found.
Yeah, thanks, Mike. I appreciate the opportunity. And, I just want to start by thanking the investigators who committed to this trial. This is a, very disruptive, mechanistic trial. It's based on 5 decades of fundamental science going back to our origins in the early 1970s, where the first concept of mechanical unloading to try to reduce or modulate myocardial ischemia reperfusion injury was introduced. Since then, of course, the technologies have changed quite a bit over the last 5 decades. We've gone from surgically implanted pumps to now percutaneous delivered pumps that can be deployed relatively quickly within a matter of minutes. And that has opened the opportunity for this type of investigation. The other important thing to note about the background is that over the last 2 decades in particular, there's been a significant explosion in fundamental science exploring ischemia reperfusion injury. And in
An
fact,
explosion of science, but no positive results, I'll add, I having done many of those trials.
that's exactly right. And there's a vast graveyard of failed attempts, whether it's drug therapy, whether it's even device therapy. I think that in the drug therapy realm in particular, one of the challenges has been that we've really uncovered and understood fundamental biology of reperfusion injury, the importance of mitochondria, for example, as triggering a lot of the infarct size that occurs after reperfusion. Um, but some of the challenges have been just getting the drugs to target, being able to deliver the drug intravenously, because there's been a rapid push towards, which is very reasonable, towards door to balloon time. And so, I spent a lot of time studying the mitochondria. And in fact, it was your trial, the Embrace STEMI trial, which got me very interested and excited about this concept of reperfusion injury salvage targeting the mitochondria. Turns out that what we learned over the last couple of decades is that in preclinical studies, that LV unloading, regardless of the method, so our first papers were using the tandem heart left atrial ventricular bypass system. Then we subsequently switched to the transvalvular system. So if you remember, the original TRIS trial was supposed to be the tandem heart to reduce reperfusion injury study. And that didn't enroll anybody because of the concept of a transeptal puncture in the middle of a STEMI before reperfusion. So some practical issues there. The transvalvular pumps then open an opportunity to study the idea of LV unloading, and that's where the DTU concept really started to accelerate. Uh, the other important takeaway for the preclinical, again, just to set the stage, is that a lot of the work that was done from Richard Smalling, from John Laschinger, many investigators over many years, started to show that pre-PCI unloading actually not only could change the biology, but also could change blood flow and microcirculation and myocardial perfusion. And there was always this need for it to be pre-PCI. And then when we conducted our studies, along with collaborators in Europe as well as in Japan, we started to learn that the window of time between unloading and reperfusion may actually be an important component of how you reduce the reperfusion injury. So you could even think of it as a mechanical conditioning of the heart for 30 or 60 minutes, and that could get a very consistent reduction in infarct size. I say all of that because this is what led to the STEMI DTU pilot and pivotal trial design. The pilot trial was published in 2019. It was designed to test whether it's safe and feasible to actually have operators put a Impella CP into a patient having an anterior STEMI without cardiogenic shock. And then the second question was, would it be feasible to even wait and have a mechanical conditioning window before reperfusion? And so that trial compared two patient populations, Impella plus immediate reperfusion, Impella plus delayed reperfusion. And what we learned was that the operators were very consistent in their ability to put the pump in and wait 30 minutes. Patients were stable, and there were no signals of any safety issues related to that approach.
Were
So
in
for
shock, but they were stable in shock, right?
correct, and they were not in shock. So that's a really important point. So these are anterior STEMIs without cardiogenic shock.
Without shock. Okay.
Correct. And that's
All
why
right.
the pilot was also quite, really pushing the boundaries because we were trying to reduce reperfusion injury.
Got it.
And
Okay. Well, that, see, I misread that's very important. So these were not shock patients. Great.
correct. And that's the idea is we're really targeting the the population of patients who suffer from ischemic heart failure, driven by these infarct sizes. And if you look across all the reports and manuscripts on infarct size, it's actually quite astounding. The anterior STEMI infarct size can range from almost a quarter to half your heart is infarcted, despite the door to balloon rapid reperfusion. So there's still much more work for us to do. The DTU pilot gave us confidence that we could enroll a pivotal. So we embarked on the pivotal, which is what we're now about to have at ACC. And the STEMI DTU pivotal trial had 55 sites around the world, enrolling about 527 patients who were then randomized to primary reperfusion, our standard of care, versus primary unloading, which means patients were brought to the cath lab as soon as they qualified for an anterior STEMI. All of them had a femoral angiogram to make sure that they could receive an Impella device. And then after the angiogram and a ventriculogram were performed to confirm anterior STEMI, then these patients were randomized. So already, even just getting up to randomization, you can see how challenging a trial like this is to perform, especially if you want to enrich the population with the right type of patients. We enrolled patients who had symptom onset under 6 hours. And so patients who had chest pain, symptom onset between 1 to 6 hours were included. These patients then underwent randomization in the cath lab and received primary reperfusion or and as an operator performing these procedures, I remember doing my first case, they received an Impella. And then there was a period of 30 minutes of mandatory protocolized waiting. And the idea was to allow the heart to rest. And then you could perform your angiogram and then your PCI. So no angiogram before LV unloading. The patients then, after reperfusion in both arms, then in the treatment arm, we then had the Impella stay in for a minimum of 4 hours and under 24 hours, and then the device was removed. And then 3 to 5 days later, a CMR was performed to quantify infarct size. Primary endpoint is a mechanistic surrogate endpoint of infarct size normalized to LV mass. The trial is not
I'm
powered
glad
for
you said
clinical.
normalized to LV mass because in Embrace, we found that bigger hearts have bigger infarcts, right? So that
Yes,
was one of the take homes. You got to normalize for LV mass. Good job.
absolutely. And, I think, MRI, CMR obviously is a in-depth conversation. It's changed quite a bit, even during the trial execution. But yes, we went with infarct size to LV mass for the reason you described, variable AARs or area at risk as well. Um, and then that was our primary endpoint. We had a powered efficacy endpoint, which was a win ratio, but that was anchored by the primary endpoint. The trial, again, was not powered for hard clinical endpoints without the win ratio. And then we had a secondary safety endpoint. And the safety endpoint's critical because we're putting in a 14 French sheath into a patient with anterior STEMI without cardiogenic shock. We're comparing it to patients who would otherwise get radial, 5 or 6 French access. So when we look at the safety endpoint, we created a performance goal, which was done in other trials as well, to really understand the benchmark of the expected bleed rate with a 14 French sheath. And so a performance goal was then put into the statistical analysis plan. So the trial enrolled from 2019 to 2024, 5 years through COVID, strong commitment from our investigators. One of the things that I think a lot of the investigators verbalized throughout the entire study was that they were actually quite surprised that patients were doing well once they were unloaded. Many patients became pain-free, and that allowed them to continue enrolling. We had operators were allowed to bail out to PCI at any time during the 30 minutes of unloading, and we had zero patients receive bailout PCI, which by itself, I think to me was one of the surprising findings when we looked at the results in 2024. The results of the trial, I think, are critically important. So when we look at the patient demographics, they follow a fairly typical STEMI trial population. We did have about 80% men, 20% women. We had patients around the age of 60. The median was 61. And then importantly, the total ischemic time, which is symptom onset to balloon time. And we know that total ischemic time correlates directly with infarct size and also mortality. We saw that there was a significant increase in the total ischemic time in the treatment arm compared to the control arm. And that's because
I,
we tested a
yeah,
two-component hypothesis, right? Impella plus 30 minutes of mandatory delayed to PCI. And so a much more prolonged ischemic time on average of about 40 minutes in the Impella arm versus the control arm. And that was basically, I think, was some of the major findings there. When we looked at, and I'll go into the subgroups afterwards, but the primary endpoint essentially was neutral between the two groups. We saw that there was a 1% absolute reduction in infarct size, which was not statistically significant. Our target was 5% in the statistical analysis plan between the two arms. When we looked at the secondary safety endpoint, we saw that the performance goal was 26%, and we observed 30% bleeding in the treatment arm population. And I'll come back to the bleeding in more detail because I think that's actually one of the key takeaways from the study is some of the variance in the bleeding. But just to close on the primary endpoint, so with the primary endpoint, infarct size normalized to LV mass, one of the things that we were concerned about, of course, is that by increasing the total ischemic time, that we might see an increase in infarct size. And the CRISP AMI study, which was balloon pump in anterior STEMI without shock, showed a trend towards increase in infarct size. And so in this case, we were actually pleased to see that there was no increase. We were a bit disappointed we didn't see a decrease in infarct size. But to me, at least as a physician, as a scientist, as an operator, when I think about what these investigators accomplished, they basically showed for the first time that you could actually potentially attenuate or terminate further expansion of infarct by unloading, even though the total ischemic time was longer. Now, that's hypothesis purely, requires much more investigation going forward. So in the end, on the primary endpoint for the clinical community, I think it is critically important for them to understand that the STEMI DTU trial results do not support initial placement of an Impella CP for LV unloading and delaying reperfusion. And I think that's really important because it is a two-component hypothesis in the treatment arm. One of the things that I think is also important for operators to understand is that there will be more investigation. We have an opportunity now because some of the subgroups actually came out quite interesting. For the median age of 61, we saw that there was a strong trend p-value of 0.06 with a 5% reduction in infarct size if you're over the age of 61. We saw that patients who were treated with beta blockers, now this was not protocolized, some operators treated with beta blockers or vasodilators during the 30 minutes. And we saw that there was also a trend towards reduced infarct size if you received a beta blocker before reperfusion. One of the things that we observed in the study was that the vast majority of patients were hypertensive. And this is also important for operators to understand. All rotary flow pumps are afterload sensitive. So when you pump against a high afterload, a mean arterial pressure of 100 to 110, you're going to have less pump efficiency. And one of the things I question in this study is, did we actually unload the patients? Because with a high blood pressure like that, You have to give adjunct pharmacotherapy to reduce the blood pressure to allow the pump to actually do its job. And that's why it
Mm,
works very effectively in cardiogenic shock, where
mm.
patients are hypotensive to begin with. So that's another area of exploration of adjunct pharma combined with a pump to reduce overall rate pressure product and wall tension to perhaps accentuate the effect. So a lot of investigation to come. I think this opens up what I believe will be a new chapter. I think even the Embrace STEMI results to me, again, because it targeted mitochondria, there's now a possibility that you could combine even drugs like the one used in Embrace STEMI with device therapy to optimize reperfusion. It's very similar to what our colleagues do in the operating room. They rest the heart, they give cardioplegia, they do a number of things to preserve myocardium. And so that's something that I think we can learn from STEMI DTU.
Well, I've been at this for longer than I care to admit, maybe 40 years. And, just keep thinking, what can we do to minimize this reperfusion injury? I think you got to intervene early, just like you did. I think you got to give the right dose of drugs. Sometimes we're too low. You got to find the right patient. You identified the anteromized. That's where all the action is at. And you got to treat, for a sufficient period of time. And you kept the treatment going. And I agree, Naveen, someday the answer may be some combination of mechanical strategies and pharmacologic strategies. As I said before, uh, nothing worth doing is easy. I know how hard these trials are. I know how hard this one in particular must have been. So, congratulations on moving the field forward. This was not a negative trial, it was a trial that was positive in terms of shedding new light on the pathophysiology. That's why we do research. I don't always look at the outcome, I look at the quality and what it added to the literature. In that regard, I do view this very favorably. Thanks, Naveen, for such a clear, honest, and readily interpretable presentation. Thanks.
Great, thanks so much.